Hello guys, welcome to our channel. Today we are going to discuss about the expected topics of upcoming July FMG examination. So before we start, those who haven't subscribed yet, please do subscribe and share with your friends. And in this videos, we are going to start with the expected topics of into three parts. Part 1, Part 2, Part 3, which will be covering all 19 subjects, most likely 30 topics for each video. Okay, so please don't miss these topics because we have gathered this, what can be expected and what are the PYTs that is most commonly asking in the past 5 years of the FMG examination. So let's start our discussion right now. Next, we are going to start the topic with the joints. We all know that the joints are in the three types. What are those guys? One is your fibrous joints, and another one is the cartilaginous, and last one is your synovial joints, right? So we also have to know what are those examples. Here you can see these are your fibrous joints. So three types of the fibrous joints. One is suture and syndesmosis and gomphosis. So sutures, we all know that coronal sutures, parietal sutures, all the sutures on our skull part, which will be your fibrous joints only. Why these fibrous joints is known? Because they are immovable. Okay, we cannot move these joints. All right. Next one is your syndesmosis. Syndesmosis is will be your tibiofibular ligament. And same with that radio-ulnar joint, which will be your syndesmosis. And the third type is your gomphosis. This is like the tooth in the socket now, that will be your gomphosis. These three are your fibrous joints. Next, moving on to the cartilaginous. So cartilaginous is subdivided into the primary cartilaginous and secondary cartilaginous. So primary cartilaginous are again, these are also immovable. And what about the secondary cartilaginous? They are slightly movable. Okay, slightly movable joints. And the primary cartilaginous are present in the epiphyseal plates and also sternomanubrium joints. These are immovable, right? Can you see that anyone can move the sternomanubrium joint? They can't. So those joints are the synchondrosis. And symphysis, the name itself tells the pubic symphysis, one of the example for the secondary cartilaginous joints. And also intervertebral joint. These are your vertebrae. In between that, there is a joint that is known as a symphysis, which is slightly movable on your, depends on the movement. Next, moving on to the synovial joints. So synovial joints, we all know that the ball and socket joint. What is the example for the ball and socket joint? One is your shoulder and another one is the hip joint. And also there is a common question that is asked last year in the examination, incus and stapes. What is this joint? Which is also your ball and socket joint. Next one is your condylite joints. What are these condylite joints, guys? Example, your knee and also your temporomandibular joint. Next one is your plane joints. All these plane joints will be your tarsal bones, in between the tarsal bones, and also intertarsal and also intercarpal and intermetacarpal, intermetatarsal. These are your inside. So in between the two joints now, that is your plane joints or the gliding joints. Next one is your pivot joints. And all the pivot joints, you have to remember the most important one, that is your atlantoaxial joint. Okay, atlantoaxial joint. And next one is your hinge joints. These hinge joints are present in the elbow, ankle and ankle, and also your interphalangeal joint. Okay, interphalangeal joint. Next, your saddle joint. Saddle joints are between the trapezium carpal bones of the first carpal bone, which is a commonly asked question also in the previous year papers. And other one, you have to remember, we can expect this one, the malleus and the incus. Okay, don't confuse. Ball and socket will be between the incus and the stapes. And how about the saddle joint? That is between the malleus and the incus. So these are the types of the joints and their examples. Next one, we are moving on to the nerve injuries. And nerve injuries also commonly asked question, right? Before the nerve injuries, there is a question, this is asked previously. What is the location of the clavicle fracture? Let's see where is the location of the clavicle fracture. So this is your medial side and this is your lateral side. So the fracture junction will be in the 1/3 of the lateral and 2/3 of the medial. So this is the common fracture that is seen in the children, and also that is common fracture that is seen in the adults. So overall, the most common is the clavicle fracture only. Okay, this is the thing that you have to remember. And next one, here you can see this is your humerus. So in the humerus, if the fracture is located in the surgical neck at this region, at the neck of the humerus, what is the nerve that is involved? So remember, this is your axillary nerve injury. Okay, axillary nerve injury. And what about the shaft of the humor? So if the shaft of the humor is injured, then it is your radial nerve injury. Okay, this can be also asked your question. And again, here you can see the patient is having the wrist drop, so he cannot lift his wrist. So these signs, specifically the wrist drop or patient having this one, this is also due to your radial nerve injury. So if there is a shaft fracture and also if there is a wrist drop, that is your radial nerve injury. And here you can see this is your foot drop. Okay, what happening in the foot drop? Basically, the patient cannot do the no dorsiflexion. Okay, patient cannot do the dorsiflexion. Patient don't have the function to do the eversion. So, and also loss of the sensory supply. This is all together will comprise to happening in this patient is the common peroneal nerve injury. Okay, this is your common peroneal nerve injury. So foot drop is due to this nerve. And here you can see the another example, the patient is having the shoulder drop. Okay, for the shoulder drop patient, likely to be the shoulder drop or the patient is having the sternocleidomastoid muscle injury. These two injuries are due to spinal accessory nerve. Okay, this is also asked the previous question. The spinal accessory nerve will cause the shoulder drop. And how about this one? The scapula is medially located and coming towards upwards. So this injury is not due to the spinal accessory nerve. This is actually due to long thoracic nerve. This is due to long thoracic nerve. All right. Next one is this is your ape thumb deformity. Patient is having the ape thumb deformity due to median nerve injury. Okay, median nerve injury. And this patient is having the partial claw hand, and this partial claw hand due to ulnar nerve injury. Okay, ulnar nerve injury. So always remember all these questions are already asked in your examination. Next, moving on to the Erb's palsy and the Klumpke's palsy. What are the nerves roots are involved in the Erb's palsy? That is your C5 and C6. And how about the Klumpke's palsy? That is your C8 and the T1. And what are the deformities? Let's see. What are the nerves that is involved? Usually in your Erb's palsy, the supra, you can remember like this SAM. What is this SAM tells? Suprascapular nerve, and also patient is having the injury of the axillary nerve and musculocutaneous nerve. And how this patient is having like this deformity. This deformity is also known as Vater's or the polystiff deformity, right? What are the major actions that is decreased in this patient? The loss of adduction. Sorry, the patient will be having the adduction and also extension and medial rotation and pronation, right? You all actions this can be seen in this patient, right? This patient is adducted. That means it is coming to near only. Abduction means going outside, and it is medially rotated, and there is only pronation that we can see. So this is what Erb's palsy patient is having. Next one is the Klumpke's palsy. Here you can see this patient is having the claw hand. One thing is claw hand. And we all say that this patient is involved the C8 and T1. At this region, we have the cervical sympathetic chain. Okay, cervical sympathetic chain. In this patient, what happened? The symptoms are usually maple. What does mean by the maple, guys? Okay, maple for the meiosis. Patient will be having the anhidrosis. And also patient will be seeing with the ptosis. And E for anophthalmos. And patient with the L, that means loss of ciliary reflex. Loss of ciliary reflex. Next, here another question. This is your Trendelenburg test. Trendelenburg is positive in which patient? Usually your superior gluteal nerve injury. Okay, superior gluteal nerve injury. What is happening in this patient? So those who are having the superior gluteal nerve injury, when the patient is asked to stand on the one foot, normal patient, these hip on the lifted foot only is going to turn to the opposite side. But the patient, those who are suffering from the disease or the superior gluteal nerve injury, so the patient will be bending on the lifted foot only. So this means the patient is positive for the superior gluteal nerve injury. And what are the muscles that are involved in this patient? Your gluteus medius and also gluteus minimus. This is the involved muscles of the patient. Okay, these are the nerve injuries that you have to remember. Next, moving on to the triangles and the fossas. So what we have discussed in the last anatomy lecture also, the cubital fossa, what are the boundaries? Remember, the superior boundary for this one is the epicondylar line, and the medial side, the patient will be having the pronator teres muscle, and the lateral side, the brachioradialis is the three boundaries on the superior lateral medial. And whatever the contents, when it is comes to the content, remember like MBBS. Okay, so medially, median nerve, and also brachial artery, okay, brachial vein, superficial radial nerve. Okay, these four are the main content of your cubital fossa, right? One thing completed. And next one is your femoral triangle. And in the femoral triangle also, your superior border is the inguinal ligament. This is your superior border. And coming to the medial side, there is a serratus, there is a adductor longus muscle. So this is on the medial side. And on the lateral side, there is a sartorius muscle. This is on the lateral side of the boundary. And what about the content of this one? So the main content is your femoral vein and also femoral artery and femoral nerve. Along with these three, the patient will be also having the lymph nodes, okay, lymph nodes and also genitofemoral nerve. Okay, these are the now this one is also present here. So these contains femoral artery, vein nerve along with the genitofemoral nerve and deep inguinal nodes. These four will be your contents of the femoral triangle. Next, moving on to the popliteal fossa. In the popliteal fossa, you just have to remember only the boundaries. That will be four types of the boundaries. Already we have discussed there is the three boundaries in the femoral triangle and the cubital fossa. In the popliteal fossa, four boundaries. Lower boundaries are easy to remember. Both sides you will be having the gastrocnemius muscle on it. On in the upper border, you will be having the two types of the muscle. On the medial side, you will be seeing the semi-membranous, and this is the muscle on the medial upper side. And on the lateral side, you having the biceps femoris. These two boundaries remember. And what about the content? Content same, popliteal artery will be presented, popliteal vein will be presented, and popliteal fatty tissue is also present here. And along with that, you have the specific nerves that is forming here. One is your tibial nerve that is also passing here, and also patient here having the common fibular nerve and the sciatic nerve. Okay, these nerves that are passing through this structure, popliteal fossa. What are those again? Recall along with me. Tibial nerve, sciatic nerve, and also common fibular nerve. Okay, these three nerves are passing through the popliteal fossa. Next one is your Calot's triangle and the hepatocystic triangle. So hepatocystic triangle will be including from the inferior border. So from the inferior border of the liver, right? This is the inferior border of your liver. And on the medial side, you will be having the common hepatic duct. On the lateral side, you will be having the cystic duct. And coming to the Calot's triangle, only the Calot's triangle, your superior border will be cystic artery. Okay, this is also asked a question in the last examination. And again here, the common hepatic duct. And here your cystic duct. That is what the most of your have to remember for this Calot's triangle and the hepatocystic triangle. Next here, another question that is asked previously, anatomical snuff box. What are the boundaries for the anatomical snuff box? So the tendons of your brevis and the longus on the upper side. Okay, this is your boundaries. Sorry. So the tendons of the brevis and the longus on the lower side, and on the upper side only one tendon, that is your longus. Okay, extensor pollicis longus, that is your upper side. And whatever the content, So the content of this one will be your radial artery. Okay, the patient is having the radial artery. So if the patient is having the injury, let's say this anatomical snub box is very painful. Why? Because of the scaphoid fracture. Okay, scaphoid fracture. That's why the patient is having the pain. So remember again, on the superior border, you will be having the extensor pollicis longus. And on the inferior border, the extensor pollicis brevis and the adductor pollicis longus. These are the things remember. And next one here, this is also image based question that is asked. So here you can see this is the thumb, this is your little finger. So on the thumb side, what is the nerve supply and what is the artery supply that you have to remember, so that you can easily remember these tendons. Okay, let's see what is the arterial supply for this sensory supply of your hand. So see, these three colors are given. So on the palmar side, you will be having the half will be supplied by your ulnar nerve. So on the lateral side of the hand will be supplied by your ulnar, and on the medial side, mostly supplied by your median nerve. So very little side that is supplied by your radial nerve. So turn to the back side. On the extensor side, what is the arterial supply? Your finger webs, your fingers, nails will be supplied by the median nerve. This all will be supplied by your median nerve. Again, the lateral side is supplied by the ulnar nerve. And extensor side, the most of the middle part is supplied by the radial nerve. So here coming to the back to this picture, here you can see what is the structure on the thumb side. Basically, it is supplied by your median nerve, right? And on the ulnar side, this is will be your ulnar. So this tendon is your flexor carpi ulnaris. Okay. And here you can see what we seen here. The little bit will be supplied by the, on the medial side, mostly by your radialis. Okay. This is your flexor carpi radialis. And how about this one? The middle one. This is your palmaris longus tendon. Okay. Palmaris longus tendon. Okay. Image based question you have to remember. So on the thumb side, radialis, on the little finger, ulnaris, the middle one which is going past through, that is your palmaris longus tendon. All right, next one. So diaphragm opening. So diaphragm opening will be, remember like this way, T8, T10 and T12. So what are the openings in the T8? Mostly this is your vena cava opening. Okay, this is your vena cava opening. Here you can see this is the vena cava opening. And next one, the T10, that is your opening of your aorta. Sorry, that is the opening of the esophagus. And next one, T12 is the opening for the aorta. Okay, and here you can see what are the structures that are passing here. In the first T8, along with the inferior vena cava, the other structures are right phrenic nerve that is passing here. Okay, right phrenic nerve. And next one, in the T10, that is esophagus always travels the vagus nerve. So it is will be vagus nerve and left gastric artery. Left gastric artery is also passing there. And in the aorta, you will be having the thoracic duct. Okay, thoracic duct and also asgius vein. Okay, now, and also esophagus constrictions from the lower molar. So here, esophagus, length, and what are the structures passing through. So at 15 centimeters, you will be having the circopharyngeal junction. At 23 to 25 centimeters, it is your aorta. And next 28 centimeters, this is your left bronchus. Okay, left bronchus. And at 40 centimeters, what is the structure here? That is the diaphragm. Okay, this is at your T12, right? This is the esophagus and their constriction points. Okay, one point that you have to remember. Both are asked in the previous year papers itself. Next one is your muscle contraction. In the muscle contraction, we all know these structures, right? Actin, myosin, that is your contractile proteins. So what are their names? this sarcomere will be contains the actin, that is your I band, and in the myosin, that is your A band. So how these bands will be come together and form the contraction of the muscle. So actin will be having the three types of the troponin. One is the trop I and trop myosin, and also it is consists of trop calcium ions. Okay. So when there is a formation of the contraction, usually action potential will be reaching the muscle. At the T tubule, it will be having the DHPR receptor, DHP receptor, and these three DHP receptor will send the action potential inside the muscle sarcomere. So here you have the ryanodine receptor that will be presented. This ryanodine receptor will send the calcium outside. Okay, this is your sarcolemma. And in the calcium, when there is a attachment of the calcium, so these calcium will be going to attach on the actin troponin. So once this will be activated, your myosin and actin will be crossing together and forming the sliding filament theory. How? This is your actin, right? And this is your muscle. So when there is a ATP, it will form and attach like this. So this is what the contraction point. Okay, myosin head is going to attach to the troponin, that is with the calcium, that is going to sliding filament theory and crossing bridge formation. So once the ATP is decreased, again the relaxation will be seen. Again ATP increase, then there will be a contraction. So like that, all the muscle contraction will be formed. So in the muscle contraction, what are the structures will be decreased? So I band length will be decreased, and also M line. So this middle line will be, M line will be changed, okay, or disappeared. And A band does not change. It will be remain constant. Okay, it will remain constant. So that's what you have to remember. I band will be decreased, M line will be unchanged, and M line will be disappeared, and A band will be remain constant. So this is what happening in the contraction of the muscle. Okay, next one, JVP. So in the JVP, you have to understand what are these waves are significance for. So A wave is for the atrial contraction, and once the A wave is having the descent is due to atrial relaxation. Suddenly there is a small wave. Here you can see the small wave is due to tricuspid valve closure. So once the tricuspid valve is closed and bulging, so it is going to bulge. Why? Because there is a ventricular contraction going on in the inside the ventricles, that will be causing the C wave. Sudden ascent will be seen. And again the descent, this is the major descent due to passive atrial filling. So when there is a filling, your vena cavas and everything will be open, is going to fill. The pressure is mostly decreased at this point. And again, there is a wave suddenly that is going to open, that is your maximum atrial filling. So once the atria is completely filled, it will be, the pressure will be increased, so that the next tricuspid valve is going to open, causing the wave descent. So this is what the JVP entire significance. So they are waves. If they are disappear, if they are changes, what are the specific conditions? If the A wave is absent, if the A wave is absent, then it is your atrial fibrillation. So if the X wave is absent, let's say X wave is absent, this is the condition like tricuspid regurgitation. And Y wave is absent. Okay, the Y descent, sorry, these are your descents. And Y wave is descent is absent. This is seen in your cardiac tamponade. Okay, don't confuse. X descent is absent, that is your tricuspid regurgitation. Y descent is absent, that is your cardiac tamponade. And also Canon A waves. Canon A waves is seen in the complete heart block. Patients, those who are having the complete heart block, this is seen. And giant A waves, the giant A waves are seen in the tricuspid stenosis. Okay, tricuspid stenosis. And prominent, okay, prominent X and Y descents, that is seen in the constrictive pericarditis. Okay, that is seen in the constrictive pericarditis. And next part, that is your pressure and the volume graph. So here also we have to understand the cardiac cycle. At the point A, what happening? The mitral valve is going to open which will be causing the diastolic filling. So this is the volume is going to happening here. And at the B point, your S1 will be caused due to mitral valve closure. Once the pressure is increased, the isovolumetric contraction will lead to ejection fraction at the C point, because aortic valve and also simultaneously pulmonic valve will be opening, which will be going to ejection of the entire blood. Okay, and D point, your aortic valve is going to cause the S2 sound, and here again the relaxation is happening. Okay, this is what the entire pressure value graph you have to remember. Next topic is the O2 hemoglobin graph. So before that, you have to know some of the terms. If the hemoglobin plus the oxygen, this is your oxyhemoglobin. All right. Next, hemoglobin plus CO, your carbon monoxide, right? And this is known as the carboxyhemoglobin. And how about hemoglobin plus carbon dioxide? That is your carb amino hemoglobin. Okay, this is your carb amino hemoglobin. And hemoglobin plus ferrous. This is your methane hemoglobin. Go methohemoglobin. These are the terms also you have to understand. Next, oxygen hemoglobin curve. There is a point that at P50 there is a specific point, the partial pressure of the oxygen is maintained. So this is your P25 mmHg. Also P50. Okay. And if the P50 is shifting towards the left side, okay, that means it is less than 50. And if it is shifting towards the right side, that is more than 50 value. Okay, this is your left and this is your right. And what are the conditions that is leading to the left side of the shift? Here you can see if there is a decreased pH value, or if there is a decreased temperature and high carbon monoxide, or the patient is having the decreased 2,3 DPG, all will lead to left side of the shift. And if the patient is having the increased pH values, increased 2,3 DPG, or increased temperature and no carbon monoxide, that will lead to right side of the shift. Okay. And what is the curve? This graph curve is known as sigmoid shape. Okay. This is your sigmoid shape curve. Okay. These points are very, very important and examples. And next one, in this part only, there is this question commonly asked on the surfactant. So surfactant, we all know that which is important and produced by your type 2 pneumocystis, right? Type 2 pneumocystis. And why the surfactant is important? Because it will increase the, it will decrease the surface tension. Okay, it will decrease the surface tension from the alveoli. Along with that, it will increase the compliance of the lungs. But when this will be going to produce? At the time of the 26 to 28 weeks of the gestation, it is present in the amniotic fluid of the mother. Okay, amniotic fluid of the mother. And when this is going to come into the baby's lungs or the fetus lung, more than 32 weeks, it will be completely matured in the fetus lungs. And if the patient, those who are born less than 32 weeks, like preterm babies, they are going to develop which disease, guys? That is your respiratory distress syndrome or the hyaline membrane disease. And coming to that test, what is the test that we can do? So majority of the surfactant is produced by your DPPC. What is this? Dipalmityl phosphatidylcholine. This is the 90% of the surfactant is made. So to test this, we have to do the lecithin and the sphingomyelin ratio. So this lecithin and the sphingomyelin ratio, we have to get from the mother's blood only. So from the fetal maternal blood, we have to test. If it is less than 2 and if it is more than 2, this is the normal. If it is less than 2, that likely to be RDS or the HMD is positive for the baby. Okay, one thing you have to remember, this is one. And this is in the congenital disease. And what about the adults? Does the other adults will having this surfactant deficiency? Yes, especially in the acute respiratory distress syndrome. In this patient, surfactant deficiency is seen. Next, moving on to another topic, that is your ABG disorders. In the ABG disorders, let's see what are the normal values first. So your normal pH value, remember like this, 7.4, and the PCO2, that is your 40 mmHg, and HCO3 is the 24 milli equivalents. Okay, 444. So whenever you see if the pH is low, that means the patient is suffering from the acidosis. And if the pH is high, that means patient is in the alkalosis. Then checking after the pH, we have to see for whether it is respiratory or the metabolic. If pH is low, but the respiratory parameter is high, that means patient is suffering from the primary disorder, respiratory acidosis. And if the metabolic acidosis, pH is low, HCO3 is low, that means the primary disorder is likely to be metabolic. And what about the compensation? Always remember, if you have the kidney disease, what is going to compensate? Your lungs is going to compensate by the hypoventilation or the hyperventilation. So same with that. If you have the lungs, then the kidney is to start the compensation. So we have the three types of the compensation. No compensation, and also partial compensation, and the complete compensation. So the compensation is already completed. How to interpret these values? So in the normal no compensation, what happens? So pH is low, patient, and HCO3 is also low. And your PCO2, what it has to do? It has to compensate, but it is normal. So that means not compensation is started yet in this patient. And partial compensation, the pH is low and the HCO3 is low. So metabolic acidosis is happening and PCO2 is compensating here. So that means the values all are deranged. That is your partial compensation. And complete compensation, your pH will be going back to the normal. What is the main cause? The pH is getting low. Alkalosis or the acidosis is going on. So it is compensated together. So HCO3 is still and PCO2 is also going to still. But pH came to normal. That means compensation is already completed. One thing, that is the compensation, and these are the values. Respiratory acidosis or the alkalosis opposite to the pH. So here you can see opposite to the pH, those are your respiratory conditions. Metabolic acidosis or the alkalosis, pH will be same. Okay, that's like only the presentation is presented. Next, you also have the anion gap. What is this anion gap? How can we calculate? So the formula for the anion gap is the sodium minus chloride plus HCO3. This is the formula for it. And there is a high anion gap metabolic acidosis and normal anion gap metabolic acidosis. What are the examples for this? When the patient is having the renal failure or the patient is having the aspirin toxicity and also alcohol, these conditions likely to be the patient will be having the HAGMA. And NAGMA for the patient, those who are suffering from the diarrhea, okay, like dehydration or vipoma. Vipoma is also condition for the diarrhea only. Our patient is having the RTS, okay, renal tubular acidosis. Our patient is taking the detox, your acetozolamide drug, okay. Our patient is having the DKA. All these patient will be having the NAGMA only. Okay, these are the conditions that we can remember as an examples. Okay, next. Next, the competitive versus non-competitive inhibition. This can be asked in the biochemistry. This can be asked in the and pharmacology also. Let's see what is the Km and the Vmax value. At least you have to remember. In the non-competitive inhibition, so the Km value will be no change. Okay, Km will be no change, whereas your Vmax will be decreased. Okay, and in the uncompetitive, there is nothing competition is going on. Your Km is going to decrease, and along with the Vmax is also going to decrease. And the competitive, always remember the Km will be increased. And coming to the Vmax, no change at all. Okay, Vmax is no change. And graphical representations, here you can see non-competitive means there is no competition in the present now. So the graph is also having the together only. So if the graph is touching the lower side of the slope, that means the patient is non-competitive inhibition of the drug is taken. And there is no competition between the two lines. They both are different sides. That means uncompetitive inhibition. And competitive, they always slide together. At one point, they will meet. On the line, upper line, they will be meeting. That is in the competitive inhibition. Next one, the oxidative phosphorylation and their complexes. Here you can see the complex 1 is going to send the succinate dehydrogenase complex 2, and complex 3 will be having the cytochrome C complex, and then complex 4 will be having the cytochrome C oxidase. So complex 5 is going to be your proton pump and the ATP synthase, and ultimately they are going to produce the ATP production. But there is a chances the inhibitors will be presented. What are those inhibitors that you have to remember? So when I say inhibitors, you have the complex one that will be including the rotenone poisoning and also biguanides, okay, and also benzodiazepines, barbiturates, and pyridine. Okay, this is also type of poisoning, pyridine. Okay, these are your complex one. Coming to the complex two, mostly your malonate. This is the common one, and also carbarin, carboxin, and complex three is antimycin, antimycin A, and also this British ball. Okay, for the poisonings we use. And complex four, for the complex 4, mostly carbon monoxide and cyanide, also hydrogen sulfide. Complex 5, only one, that is your oligomycin. These are the most of the competitive inhibitors present in the these oxidative phosphorylation. They are thermogens also, physiological uncouplers. What are these physiological uncouplers present? Most commonly fever. Fever will cause the increased thermogens, right? And another T, that is your thyroxine. Okay, increased thyroxine means the basal metabolic rate is increased. That will also lead to physiological uncoupler. And also bilirubin. So this bilirubin is for the main of the liver function. That means derangeation also can lead to physiological uncouplers. Along with that, increased long chain fatty acids. These can also lead to physiological uncouplation. Okay, remember this example case. Next one is the vitamins and the mineral deficiencies. What is this one? This is a classic condition, vitamin A deficiency. And in the vitamin A deficiency, what is this one? This is the white hot spot, right? White hot spot. And most commonly, this is the most common sign present in the xerophthalmia patient. And in vitamin A deficiency is the most common blindness also. In the children, the most common painless blindness is due to vitamin A deficiency. Along with that, there is a follicular dermatitis on the elbow regions. So follicular dermatitis is also seen in the patients of the vitamin A deficiency. What is the treatment for the vitamin A deficiency? Day 1, you are going to give, day 2, and also day 14. What is that? International units of the vitamin A injection should be given for this patient. What are the dosage? If the 50K international unit, that means less than 6 months babies. And 1 lakh units, 1 lakh international units for the 6 months to 12 months babies. And 2 lakhs international units for the 12 months to 5 years babies. Okay, this is the dosage for the vitamin A. And next one here you can see this is the classic condition. What is this condition? Gum bleeding the patient is having, likely to be scurvy. And scurvy is due to deficiency of the vitamin C, right? And along with that, why the patient is having the gum bleeding? Due to collagen defect. If the collagen does not have the vitamin C, there is no hydrolysis happening and every organ, every system will be disturbed. So along with the vitamin C, scurvy patients will be having the bone deformities and also patient will be having the skin changes, patient will be having the gum bleeding and also poor wound healing. Okay, all these symptoms will be present in this scurvy patients. Next one, here you can see this is your B9. Sorry, this is your B3, right? Niacin deficiency. And in the niacin deficiency, pellagra condition. What is this pellagra condition? We all know, right? D, D, D. If you don't treat, then another D. What are these? Diarrhea, okay, dementia, dermatitis. Okay, this is the cassel necklace appearance on the sun exposed areas. So this patient, if you're not treated, death will be seen. What are the causes pellagra? Heart nerve disease can be, and also patient those who are suffering from the maize eaters, okay, B6 deficiency, all this lead to niacin. And most commonly alcoholics also. Okay, alcoholic patients also. Next, moving on to the another one, that is where B1, thiamine deficiency. Thiamine deficiency can be two types. If the patient is taking a polished rice, these polished rice patients will be having the very disease. And very can be two types. One is your wet for the heart disease and another dry, that is for the neurological. Okay, neurons will be involved. So another one, Wernicke's encephalopathy. In the Wernicke's encephalopathy, most commonly alcoholic patients. These alcoholic patients will be having the symptoms of what? GOA, global confusion will be seen in this patient. Ophthalmoplegia. Okay, ophthalmoplegia means the patient will be having the any kind of nystagmus or the palsy is seen. And coming to the A, this is for the ataxia. Okay, gait changes is also seen in this patient. Now, next one is your B2. B2 is for the riboflavin. Usually angular chelosis. Okay, on the corners of the mouth, angular chelosis, and patient will be having the stomatitis, means tongue inflammation, corneal vascularization. Okay, these are the conditions that can be associated patients with the B2 deficiency of the riboflavin. Next, your B9 and the B12. These two is going to cause the anemia only. Okay, megaloblastic anemia. Okay, and megaloblastic anemia, how to differentiate? If you see homocysteine levels, okay, homocysteine levels is elevated, but methyl malonic acid is normal. Okay, this methyl malonic acid is normal, then this patient is suffering from the B9. And if the patient is having the B12, what happened? Homocysteine levels are elevated and methyl malonic acid is also elevated. And seen in which patients? Usually vegans and also alcoholics. And if the patient is not treated, megaloblastic anemia is okay. But along with that, there is this condition, subacute combined degeneration. So entire spinal cord, peripheral nerves, all is going to degenerate. And in the folate deficiency, if it is not treated, neural tube defects can be seen in this patient. Right? This is one of that. And next, vitamin D. Okay, vitamin D, we all know that that is due to rickets. Okay, rickets patient is likely to be having this condition. And ALP is elevated in this patient. Along with that, the PTH, the parathyroid hormone, the vitamin D is decreased and phosphorus is increased. This is what vitamin D rickets patient. And next, you also have the minerals. First one is your zinc. So zinc will cause the acrodermatitis enteropathica. What is this condition, guys? Acrodermatitis enteropathica. Means you can understand acrodermatitis means this will involve only the specific regions. For example, anus, for example, mouth. These two regions, symmetrically lesions will be presented. Enteropathica, along with that, patient will be having the diarrhea and diaper rashes. This zinc is also important for the wound healing. So if the patient is deficient, poor wound healing also seen. Next one is the selenium. Selenium can cause two types of the diseases. One is the Cation-Beck. This Cation-Beck will be involved the diabetes cardiomyopathy. Okay, the heart is involved. And if it is Cushing disease, this will be including the degenerative osteochondropathy. Okay, means the bone disease involved. Next, coming to the copper. Copper have the two types. One is the Menkes and another one is the Wilson's. Okay, in the Wilson's patient, this is due to ATP7B gene and Menkes is for the ATP7A gene. And Menkes patient will be having the kinky hair. Okay, classically they will be having the kinky hair and also eye abnormalities all this seen. In the Wilson's disease, this is due to copper buildup. And what happens? This patient will be having the Kehr Fisher ring that you can see in the eye basement membrane and also lenticular degeneration. Once the copper will be leading to the blood-brain barrier, this will cause the lenticular degeneration. And what is the gold standard test for this patient? That is the urinary excretion. So urinary copper excretion should be monitored for this patient. Okay, these two conditions are for your copper. Okay, at least these minerals and these vitamins should be known for the examination. So next, moving on to the next topic, oral hypoglycemic drugs. At least 2 to 3 questions can be asked. So first one is the biguanides. So in the biguanides, we have the most commonly widely used drug of the choice for the type 2 diabetes mellitus, that is your metformin. So what is the most mechanism of action for the metformin biguanides? It will decrease the hepatic glucose production. Okay, it will decrease the hepatic glucose production. Along with that, it will also decrease the LDL and weight neutral drug. This can be. And what is the other benefit of this? The metformin, over the time, it will also increase the insulin sensitivity. Okay, these all benefits will be likely to be beneficial for the patients. And what are the side effects? Mostly the vitamin B12 deficiency is seen in this patient. Lactic acidosis, this is also one of the common cause and rarely seen. Along with that, if the patient is having the less than GFR 30, so we should not give the metformin. Also in the extended like end stage renal disease also we should not give. Okay, these are the only things that you have to remember about the bicarbonate. Next one is your DPP-4 inhibitors. These DPP-4 inhibitors will increase the incretins. Okay, this will increase the incretins in the body. What are the examples? Whichever will be ending with the gliptins. Okay, your sitagliptin, linagliptin, all these drugs are your DPP-4 DPP-4 inhibitors that will increase the incretins, which will eventually decrease the glucagon and which will eventually increase the insulin in the body. Right? This is the best drug only. And what is the side effects? Usually, rarely, pancreatitis only seen in this patient. And liver disease patient, renal disease patient, we should not give these drugs. But there is an exception in the sitagliptin, tedagliptin. So the drug tedagliptin can be given in the patients those who are suffering from the kidney disease. Okay, this drug is the safe. And next one is your GLP-1 agonist. And GLP-1 agonist drugs are only present in the SQ form, okay, subcutaneous form. What are those? The glutides, semaglutide and linaglutide. All these drugs are from the glutide ending. So these drugs usually this is also not safe in the renal patients. Okay, in the renal patients, you should not give contraindicated. But what can be given? Another exception, linagliptin. So linaglutide can be given for this patient. These are the two drugs renal safe only. All right. Next, moving on to the mechanism of action, same. It will also have major role of the incretin increasing and glucagon will be decreased, insulin will be increased. Same side effects, pancreatitis is seen in this patient. All right. This is the one of it. And there is a new drug recently launched that is one GLP-1 and also GIP-1 that is your terizipatide. Okay, this drug is your terizipatide. Recently in the US, this is a common drug. And this is your famous drug, Ozempic, the mostly used for the obesity patients. So next one is your alpha glucosidase drugs. Alpha glucosidase drugs, what are those examples? Your acarbose, voglibose, or the miglitazole. These drugs are your alpha glucosidase. What is this will do? It will decrease the carbohydrates absorption. Usually carbohydrates will be the increasing the glucagon, right? So if you decrease this absorption, there is a no increasing of the glucagon. So this will, the side effects will be GI symptoms only, flatulence, diarrhea, like that. The symptoms will be presented. And what is especially IBD patients and the liver disease patient, these drugs are contraindicated. Okay. Next one is your SGLT2 inhibitors. These SGLT2 inhibitors will be working on the kidneys at the PCT level. What happens? These inhibitors will be causing the glycosuria. So most of the urine will be passed out along with the glucose excess levels. This is the best drugs that can be given in the patients with the congestive heart failure. Drug of the choice for the patients, those who are suffering from the congestive heart failure and the diabetes mellitus. Okay. And what it will cause, if there is a more glucose, there is a high chance of the bacterial growth in the patients, which will be leading to recurrent UTI and also vaginal infections. Okay. Another side effects. Next, moving on to the other classification, that is your sulfonylureas. Okay. Sulfonylureas, these drugs are mostly your glimepiride, glimepiride. These drugs. What is the most mechanism of action for this one? Usually, it will be acting on the beta cells. Directly on the beta cells of the pancreas, it will increase the insulin levels. So, highly potent. Okay, this is highly potent drug. That's why the patients, those whoever taking this will be having the hypoglycemia in these patients. Okay, this is the one of the side effects, and also it will cause the weight gain. Okay, this is the sulfonylureas drugs. Okay, only these drugs, one of the most commonly used in the oral hypoglycemic drugs, and their side effects are very, very important for your examination. Next, moving on to the antihypertensives. In the antihypertensives, basically, when there is a patient, those who are having the 140 by 100 mmHg, so then we consider this patient as a hypertensive. In this patient, the first line of the therapy, the drug of the choice for this patient is, nowadays, we are going to start this patient on the ACE inhibitors or the ERB inhibitors. Okay, ACE inhibitors or the ERB drugs. What are those? Your captopril or the lisinopril or the losartan. These drugs can be given. Let's say that the patient is having the hypertension along with the some of the comorbidities. For example, the patient is having the diabetes mellitus. Then you can start this patient on the ERB drugs. What are those? Telmisartan is one of those best drugs because telmisartan will be working as a PPAR gamma. So both it will decrease the hypertension and also it will be very beneficial for the patients with the diabetes mellitus and patients hypertension with the osteoporosis. This osteoporosis patient, what we can give? We can give the thiazides because thiazides is very helpful for the hypercalcemia, right? It will maintain the calcium levels in the body. And hypertension plus patient is having the CKD or patient is having the heart failure. These patients also we can start on the ACE inhibitors as a drug of the choice. And if the patient is having the hypertension along with the benign prostatic hypoplasia, these patients we can start on the alpha agonist or the alpha blockers. Example, your prazosin. This drug can be given. And patient is having the hypertension. Then the patient is having the increased LDL levels. This patient we can give the losartan. What is the famous thing that the losartan will do? It will decrease the LDL. It will decrease the gout symptoms. It will also decrease your hypertension. So it will be worked as a three properties. And patients, those who are having the hypertension plus a Raynaud or the systemic other vasculitis, then we can start the patient on the calcium channel blockers like nicardipine, amlodipine can be given. And subclassified if the hypertension patients having the more than 180 by 100 mmHg or 110 mmHg. So let's see that the patient is having the multi-organ dysfunction present and another patient is not having the multi-organ dysfunction. What are the drug of the choice? So this is considered to be the emergency. In this patient, we have to give for the IV. What are the drugs? IV nicardipine can be given. Okay, this is the one of the drug of the choice, or you can go for the IV sodium nitroprusside. This drug can be also given. Very systemic vasodilation is seen with the sodium nitroprusside. And patients, those who are not having the any comorbidities or patient is not having organ dysfunction, then you can give the oral drug because this is considered to be the urgency only. What is the drug? Clonidine can be given for this patient. Okay, and but it will change in the patients those who are suffering from the hypertension in the pregnancy. These patients, whether the patient is having the emergency or the urgency, you can go for the labetalol. Okay, immediately you can give this drug of the choice for this patient. All right, next moving on to the anti-gout. So first we see the what is the classification of the gout. Gout is commonly associated with the acute or it can be as a chronic one. And even it is also seen as a pseudo gout. How to differentiate? In the acute gout, mostly patients will be having the tophi production. And why this tophi production? In this both acute and the chronic gout, mostly due to monosodium crystals. These monosodium crystals will be built up, which will be causing the pain. Example, which patients will be having, especially alcoholics or the post-menopausal old patients, these symptoms will be having. And what is the joint that is involved? The most commonly, it will involve the metatarsophalangeal joint. Your big toe will be involved. Okay, and in this patient, if you check the acute patients now, the patients will be having the normal uric acid levels. In the chronic patients, uric acid levels will be increased. Only that is the major difference. And if you do the investigation of the choice, that is the aspiration. And after checking the aspiration under the microscopy, you will be seeing the needle-shaped negatively charged crystals. This is what found in the acute or the chronic gout patients. Coming to the pseudo gout patients, this will be having the knee joints involved and this patient will be having the calcium crystals. Okay, calcium pyrophosphate crystals will be built up in this patient. And when you check this patient's microscopy levels, they will be having the positively charged polygonal shapes. Okay, all P, your pseudo gout, which will be having the pyrophosphate calcium positively charged polygonal shapes. This is what found in the pseudo gout. And coming to the what is the drug of the choice for each and every patient. In the acute gout patients, what you can do, you can start the patients on the NSAIDs like your indomethacin drug can be given for this patient. Okay. And coming to the, if it is not controlled, then go for the colchicine. This colchicine drug will do the decrease the neutrophil migration. So inflammation will be likely to be decreased in this patient. But the patient came now chronic because uric acid levels is also high in this patient. Now you have to start this patient on the allopurinol or the febuxostat. These febuxostat or the allopurinol, what is the mechanism of action? There will be xanthase inhibitors. Okay, these drugs are your xanthase inhibitors. So the uric acid levels will be decreased in this patient. And what about the uricosuric? If the uric acid is building inside, you can excrete this from the kidneys. What are those drugs? Your probenecid. These probenecid can also be given in the patients, and along with that, what we discussed, the losartan can be decrease the uric acid levels also. And what are the drugs that we have to avoid to decrease the uric acid levels in the body? Mainly, we have to avoid the thiazide drugs, which will be causing, and also loop diuretics. These two drugs will increase it. And patients, those who are having the CKD patients also, we can start them on the probenecid. And another condition, you all know that this is the tumor lysis syndrome. In this tumor lysis syndrome, the drug of the choice for this patient is your rasiburicase. What is this rasiburicase? Basically, this is a uricase analogs. Okay, uricase analogs. Okay, this is one thing. Next, moving on to the anti-glycoma. In the anti-glycoma also, we have the two types, acute open angle and acute closure angle, right? So what we have to do, basically in the patients, those who are having the open angle glaucoma, either you have to repair the trabecular meshwork, or you have to increase the uveoscleral flow. In this patient acute closure, you have to decrease the mainly you have to decrease the aqueous humor production in this patient, right? This is what the main goals of this drug of the choice. So let's see classification. The first one is your prostaglandin F2 alpha drugs. These F2 alpha drugs, the best drug is your latinoprost. And this is the drug of the choice for the patients, those who are suffering from the open angle glaucoma. And what is the mechanism of the action? It will increase the uveoscleral pathway. This is the minor pathway which will be clearing the whatever the pressure is built up due to aqueous humor. So the flow will be gone with the uveoscleral pathway. But there is a something side effects that is concerning. What are those side effects? Especially you will be seeing the hypertrichosis in this patient. Along with that, iris pigmentation is seen. High chances that the patient can be having the uveitis risk, and also cystoid macular edema is also seen in this patient. The next one is your alpha agonist. In the alpha agonist drug, you have the two types of the drugs. One is your apraclonidine and another one is the bromonidine. These drugs will, what is the mechanism of action? In the alpha agonist, this will be having the decrease the trabecular flow, decrease the trabecular outflow, and along with that, it will increase the uveoscleral pathway. Why it is going to decrease the trabecular outflow? Because if the trabecular meshwork is already blocked, something is filled there, so there is a high chance the IOP will be increased. So it will also increase the uveoscleral pathway. And there is specific side effects will be seen with the differently for the both. Bromidine will be having the depression because it will going to cross the blood-brain barrier. So it will cause the depression and also drowsy. Patient will be having the apnea. So never give the B drugs in the C. What is this? In the children patients, you have to should not give this drug. All right. Next, apraclonidine having the other symptoms. What are those other symptoms? Patient will be having the follicular conjunctivitis, and lead retraction. Okay, lead retraction is also seen in this patient, those who are taking the apraclonidine. Next one is your beta blockers. These drugs, the topical one is the timolol. And the patients, those who are taking the beta blockers, same, it will also increase the uveoscleral pathway. And the side effects are seen BBC. What is this mnemonic for the BBC? B for blepharoconjunctivitis. Okay, it will be blepharoconjunctivitis. Along with that, blockage of the nasolacrimal duct and corneal anesthesia. And last one is your carbonic anhydrase inhibitors. These carbonic anhydrase inhibitors, what are the drug? The oral drug, what we give, acetozolamide. It is given after the patients, those who are taking the acetozolamide now, we can give this drug after giving the mannitol. So mannitol is the drug of the choice for the closure angle glaucoma. After that, we are going to give the start dose of the 200 mg acetozolamide. This will also, what basically it will increase the uveoscleral flow. Okay, uveoscleral flow of the patient. What is the side effects? Mainly patient will be having that given the oral now, it is going to cause the metabolic acidosis, and also patient is having the renal stones formation and RTA. to injury. This is the things that can be happened in this patient. Okay. And last one, myotics. Myotics, like what is the myotics drug we can give for this patient? Pilocarpine. This is also given for the closure anti-glaucoma. Usually this will cause the brow ache. Okay, your eyebrow it can be caused by this drug. All right. Next, moving on to the anti-arrhythmic drugs. When I say anti-arrhythmic drugs, you have the classification 1, 2, and 3, 4, and also we have the miscellaneous one, 5th class. Okay. So first one again subdivided into the 1A, 2A, and 1A, 1B, 1C. Okay. This is how subdivided. What is this? 4 classifications. Mainly, it is going to block the mnemonic can be remembered as a Sonali Bimre and Priyanka Chopra. Okay. So first one will be due to blockage of the sodium channel. Okay. It will block the sodium channel. It will block the beta blockers and your P for potassium and C for your CCB. And what is this 5th one? This is a miscellaneous drug. We will be discussing it last. So first one, sodium along with the sodium plus it is going to also block the potassium. So both will be blocked. And in the 1B, only sodium is blocked and potassium is normal. And sodium is blocked in the 3rd one, but potassium has no role. Okay, this is what the 3 classifications of the 1A drugs. What are those drugs? You have your prokinamide. Okay, prokinamide drug is basically given in the patients those who are suffering from the WPV syndrome. Arrhythmias patients along with the WPV syndrome, we can give the IV dosage of the prokinamide. And next one is your quinidine. This quinidine also given for the patients those who are suffering from the AFib or ventricular arrhythmias. What there is a risk if you give these 2 drugs, there is a high chance QT prolongation is seen because your potassium is also blocking here. So QT prolongation is risk with your 1A drugs. Okay, one thing. And next one is your lidocaine. Okay, this lidocaine and also your phenytoin. These 2 drugs are present in the 1B drugs. And what is the risk of this lidocaine? You all know it will decrease the MI induced arrhythmia. It will also decrease the digitalis induced arrhythmia. But there is a high chance it can cause the malignant hyperthermia. Okay, malignant hyperthermia is seen this lidocaine infusion. Next, your 3rd classification will be having the propranolol or the flecainide. Okay, flecainide and also propionol. These drugs. These both will be increasing the other cholinergic symptoms. Okay, cholinergic symptoms as a side effects. Okay, this is the one thing that you have to remember. And 1C has a specific thing. These are most arrhythminogenic. Okay, arrhythmogenic drugs are your 1C drugs. Next, 2 classification. You all know whatever the drugs will be ending with the lols, so all will be classified under the beta blockers. Basically, why will you to decrease the heart rate, especially AFib and also flutter. These 2 cases we are going to prefer the beta blockers for these patients. And symptoms will be bradycardia, bronchospasm, and patients those who are taking the asthma medications, we are not going to give the beta blockers. And coming to the potassium channels. Potassium channels will be having the drugs like ibutylite and most common best arrhythmogenic, that is your amiodarone, and also drugs like sotalol. Sotalol is a beta blockers, but it also have the potassium role. So all these potassium channel blockers will be having the high risk of the QT prolongation. So torsades risk is with 2 types of the drugs. One is your 1A drugs and another one is the 3rd class of the arrhythmogen. And most common with the ibutylite and least common with the amiodarone. All right. And these drugs can be given for any arrhythmias. Most friendly arrhythmogenic drugs are your potassium channel blockers. And in that, the best drug is the amiodarone. All right. Next, 4th one is your verapamil. These verapamil drug and the diltiazem drug we are going to use here. And verapamil is given for the PSVT patients with the other comorbidities like asthma patients. We can give this verapamil and the diltiazem. And 5th classification, as I said, this is the miscellaneous drugs such as your atropine. Atropine is given for which patients, guys? Those who are suffering from the bradycardia, Okay, Brady patients we can give. And another one, adenosine. And adenosine is the drug of the choice for the PSVT and MGSO4. IV MGSO4 is given for the torsades, depointers, these patients. And last drug is your digoxin. Digoxin is given for the heart failure plus the arrhythmia patients. Okay, these are the drugs that is given in the classification of the fifth miscellaneous drugs. Next, moving on to the anti-epileptics and their mechanism of action. So the sodium valproate. So these sodium valproate is a commonly used drug because it is a wide spectrum drug. What it is going to block? It is going to block the sodium channels. Along with that, it is going to block the L type of calcium channels. It will also increase the GABA inside the neurotransmitters and it will decrease the glutamate. This is the common wide variety of the mechanism. That's why most commonly this drug is the drug of the choice for the GTCS and also patients those who are suffering the myoclonus tonus epilepsy and also absent seizures in the India. Okay, wide variety of drug that is used, that is the sodium valproate. Next one is your ethosuximide. This drug is only having the minor action. Specifically, it is going to block your calcium channels. And this is the drug of the choice for the worldwide. We are going to give this drug only, but due to it expensive in the India, we are going to use the sodium valproate. Next one, common drug, that is your phenytoin. This phenytoin is also going to block the sodium channels. Okay. Next, carbamazepine. Carbamazepine is going to block the sodium channels. Okay. And remember, this is also asked in the previous mechanism of action. And phenytoin side effects is also asked. Gingival hyperplasia is seen in the phenytoin. Fetal abnormality or the Hyalidin syndrome, that is also seen with the phenytoin only. Next, coming to the pregnancy patients with the epilepsy. Whenever you see pregnancy patients with the epilepsy, basically if the patient is came to our OPD at the first trimester and she is on the sodium valproate, what we can do? And can we change this drug or not? So don't change in the pregnancy. But let's say the patient is came before the conception. Okay, before the conception. So now change the drug. Okay, now change the drug. What is the best drug that we can give for this patient? Levetiracetam. Okay, levetiracetam we can give for this patient. Okay, this is the drug of the choice for the pregnancy safe. The next one is your poisons and the antidotes. Organophosphate patient, what we are going to give? Atropine. Along with that, we can start the patient on the pralodoxin. These both can decrease the acetylcholinesterase, the toxicity in the patient. And there is a other drug, carbamate. In the carbamate, it is an irreversible poisoning. We cannot give the pralodoxin. At least we can give the patients the atropine drug of the choice. And patients those who are taking the paracetamol or the NSAID's toxicity. In this patient, we can give the N-acetylcysteine as a drug of the choice. Patients those who are taking the benzodiazepines, like your all the drugs which will be diazepam, all these drugs, what we can give for this patient, the flumazenil can be given. Okay, flumazenil can be given. Patients those who are taking the methanol or the another type of the ethanol, which is a very toxic, or in this patient we can give the formimazole. Okay, and patients those who are taking the opioids, these patients we can give the naloxone. And iron toxicity, we can give the defroxamine. And those who are taking the lead toxicity, EDTA can be given. All right. Cyanide patients. In the cyanide patients, basically your B12 pathway is gone. So for this, we can give the IV injection of the B12. Along with that, you have the another drug that is your amylitrite, and also sodium thiosulfate can be given. Those who are having the beta blockers, for this patient, we can give the IV glucagon as a drug. CCB patients, those who are taking the calcium channel blockers, high side of the calcium channel blockers, for this patient, you can give the calcium gluconate. And those who are taking the diabetes mellitus toxicity, in this patient, you can give the insulin. Sorry. So those who are taking the high diabetes mellitus will be having the hypoglycemia risk. In the hypoglycemia patients, what you can give? Again, you have to give the glucagon, right? Next, patients having the heparin toxicity. So for this, we have to give the protamine sulfate. Warfarin, we have to give the vitamin K. Vitamin K for this patient. Next, those who are taking the digitalis, these digitalis toxicity, we can give the digibind. For the atropine or the datura poisoning, atropine or the datura, for this patient, you can give the physiostigmine. And those who are having the carbon monoxide poisoning, hyperbaric or the 100%, hyperbaric or the 100% O2 therapy is given for this patient. And next topic is the anti-cancer drugs and their specific side effects. Commonly asking question also this one. Before that, we will see some of the other causes and their specific side effects. When I say pulmonary fibrosis, this can be due to multiple drug causes. What are those drugs? We are having the mnemonic with the vehicles only. So the drug that is will be methotrexate. Okay, like this is a truck, and busfulvin. Okay, bus. And next one is a bleomycin, like horn blowing. And next amiodarone. Okay, some kind of car. And next nitrofurantine, cyclophosphamide. Okay, these drugs, like you can see the truxate, busfulvin, bleomycin, amiodarone, nitrofurantine or the cyclophosphamide, which all will going to cause the pulmonary fibrosis. And next one is your agranulocytosis. These agranulocytosis can be seen with the C type of the drugs only. What are those C drugs? One is your carbamazepine. Okay, this is an anti-epileptic drug, right? Carbamazepine. And another one is the clozapine. It's antipsychotic drug. Clozapine can be caused. Or the carbimazole. What is this carbimazole? Your anti-thyroid drug for the Graves' disease patient. And chloramphenicol. Okay, chloramphenicol can also cause the agranulocytosis, and blue man syndrome is also caused by the chloramphenicol. Colchicine can also cause this specific side effects. All C drugs, agranulocytosis. Next one, lupus. So drug-induced lupus is caused by the sulfonamides, and also hydralazine and isoniazid prokinamide. Okay, these drugs. So mnemonic like SHIP. Okay, SHIP mnemonic for the drug induced loop. Especially this is going to positive for which type of the antibodies? Antihistone antibodies. Okay, antihistone antibodies. Next one is the gynecomastia. So gynecomastia is caused by the some of the drugs. Remember mnemonic DISCO. What is the drugs? Digoxin. Again isoniazid. Spironolactone. Okay, this is for the estrogen. And this is cimetidine. These drugs will be causing the gynecomastia. Next, anti-cancer drugs. Here, the chemo man itself will be telling our answers. For the ears, these C shapes for the kidneys and the ears, that is belongs to the cisplatin and the carboplatin. The platinum compounds will be causing this toxicity. Next, the vincristine, all the drugs which will be causing the V-shaped, this is going to cause the peripheral neuropathy. Okay, the vincristine kind of drugs. Next, the drugs coming from the D and T. These two drugs are cardiotoxics. What are those? Trastuzumab and also doxorubicin and donorubicin. These drugs will be causing cardiotoxicity. Along with that, the cyclophosphamide is going to cause the hemorrhagic cystitis, right? This is also asked questions only. And patients, those who are taking the methotrexate or patients taking the 5-fluorouracil or the pyrimidine derivatives, that will be causing the myelosuppression. And one of the question is asked, hand-foot syndrome. Hand-foot syndrome is caused by which of the following drugs? Then you have to mark 5-fluorouracil. Okay, and radiation recall syndrome. Radiation recall syndrome is caused by which of the following drugs? This is caused by your doxorubicin. Okay, So this chemo man is going to help our side effects and also these specific syndromes. These other side effects drugs are very, very important. Next, moving on to the TB drugs. So TB drugs, we have the fourth kind of the drugs. One is your rifampicin, that is going to cause the side effects like orange body fluids and highly hepatotoxic. And patients, those who are taking the isoniazid, basically they will be having the peripheral neuropathy. Why? Because of B6 deficiency. And these patients with the pyrazinamide, this is highly ototoxic. And absolutely, this is contraindicated in liver disease patients. And also, it should not be given in the gout patient. It will increase and aggravate the gout symptoms. Ethambutol, E for ethambutol, E for the eyes. Okay, it will cause the optic neuritis. These specific side effects are very important. And ethambutol is contraindicated in renal failure patients also. And rifampicin also have the other point, that is potent CYP450 inducer. So if you take this drug along with that, it will decrease the OCBs and also warfarin. So high chance of bleeding can be seen and also pregnancy can be caused. So if the patient is having the pregnancy due to hepatotoxicity, and this is not good for the pregnancy patients. All right, this is the TB drugs. And let's see what is the leprosy patients. In the leprosy patients, we give the three types of the drugs. For example, you take the paucibacillary patients. These paucibacillary patients and the multibacillary. The paucibacillary lesions are less than 5. The multibacillary more than 5. Plus nerve is involved in this patient. What is the therapy? This is given for the 6 months treatment and here 12 months treatment. Okay, 12 months treatment. What is those drug of the choice? The first one is the rifampicin. Okay, this is your rifampicin drug, 600 mg. Second one is the dapsone, 100 mg for the patient. And third one is your clofazimine. This is 300 mg plus 50 mg. Okay, rifampicin is given only monthly once. This is given daily. D for dapsone, D for daily. And clofazimine 300 mg is given monthly once, but the 50 mg is given daily. Okay, this is the treatment for the leprosy patients. Next, coming to the malaria treatment. This is also commonly asked question in the examination. So malaria patients, when I say Vivax, so only drug of the choice for the Vivax patients is the chloroquine. Regardless northeastern areas or any areas in the India, this is given for the 3 days of the drug. Along with that, we will also going to give the primaquine for the 14 days because the relapse is caused by this Vivax patients, right? So to avoid this relapse, we are going to give the primaquine for the 14 days. Okay, this is the treatment. And Vivax patients with the pregnancy, if they are pregnancy, for this patient, we are going to give the same drug. Okay, chloroquine only given for this patient. Next, coming to the falciparum. So falciparum patients, only these patients, what we are going to differentiate is the northeastern areas because these are resistant areas. Northeastern areas, our patient is from the other areas of the India, other state. We have the two protocols. One is in the northeastern areas, we are going to give the artesunate plus artemether and along with that lumefantrin. Okay, lumefantrin. And only one day we are going to give the primaquine. Even though falciparum does not have the any relapse, still primaquine is given. So this is the treatment for the northeastern areas. Okay, artesunate, artemether, lumefantrin, primaquine. And other state patients, we are going to give the artesunate. Artesunate is common. Along with that, sulfadoxine and pyomethamine. This is given for this patient and still again primaquine is also given. And in the pregnancy patients, so in the pregnancy patient, we are going to give the first trimester quinine and in the second trimester, same treatment. Okay, same treatment. But pregnancy patients, any patients, we are not going to give, that is contraindicated primaquine. Okay, primaquine should not be given. That is what the whole malaria treatment protocol. Next one, radio resistant versus radio sensitive. So radio resistant, which of the phases in the cycle is mostly radio resistant? That is your G1, which is more than the G1 is more for the radio resistant. And radio sensitive, mostly your G2 and M. Okay, this is one question. And what are the organs? So the radio resistant organs are bladder and also connective tissue. Along with that, there is a platelet which will be also included as a radio resistant. Fibroblast and neurons is mostly radio resistant, and most of the sarcomas are also radio resistant cancers. Okay, these are the points that you have to remember. When it comes to the radio sensitive, bone marrow and also gonads and lymphocytes and leukemias and the seminomas are mostly radio sensitive. Okay, and also in the radio resistant, you can also add the point which of the following organ that can be vagina also. Okay, this is table is commonly asked in the previous papers. Next, genetic disorders. How can you identify the genetic disorders? In the autosomal dominant, this is the most common, and all the patients, all the generations will be included. Here you can see the father is affected and 50% of the genes is came in both children. And same with this, and they also got this disease. So 50% of the genetics and every generation is affected. That is the autosomal dominant. And autosomal recessive, if they are having a consanguineous marriage and likely to be, if they both are carriers, they will also transmit one of the individuals. So there is no complete penetrance, but they will follow the formation of the carriers, and also they are going to produce the one of the deceased individual. This is your autosomal recessive. And next, X-linked disease. In the X-linked disease, you have the two types, X-linked dominant and X-linked recessive. What does mean by the X-linked dominant and the recessive? Basically, your dominant patients all are going to come from father to the daughter. In the recessive, the mostly mothers is going to transmit to the males. But these both are the carriers. Okay, they are only carry the disease, and these individuals are going to get the disease. Okay, so father is a carrier going to transmit to the daughter disease, and mother is a carrier going to transmit the disease for the baby. And next one, mitochondrial inheritance. The mitochondrial inheritance is done by only the mother. So mother will transmit disease to the babies. Regardless of the gender, it is transmitted to the babies. That is what the mitochondria. Let's see examples here. What are those examples? In the autosomal dominant, remember the mnemonic AD don't have the A. Okay, what is that? So dystrophia, mitonia, osteogenesis imperfecta, neurofibromatosis, tuberous sclerosis, and hereditary spherocytosis, achondroplasia, von Willebrand disease, Ehlers-Danlos syndrome, ADPCKD, and the patients, those who are suffering from the intermittent porphyria and Marfan syndrome. In all these diseases, most common one is the Marfan syndrome. And what is the example for the autosomal recessive? Just remember all the enzyme deficiencies. This all belongs to the autosomal recessive. Mnemonic, alkoptonuria like ABCDGFH, beta and the alpha thalassemia, cystic fibrosis, deafness, emphysema, Friedreich ataxia, Gaucher disease, and the homocystinuria. And X-linked dominant, most commonly your Fragile X syndrome, Charcot-Marie tooth, Alport syndrome, rickets, and the Rett's disease. And X-linked recessive, Akshay can fight, dance, give him the cold water is the one of the mnemonic. And agammaglobulinemia, chronic granulomatous disease, Fragile X is a controversial, but if you have the answer, best choose this one only. Okay, Fragile X. And Duchenne muscular dystrophy, G6PD, hemophilia A and B, color blindness, and the viscoitis. And you can also remember this way, X-linked recessive, mostly your like immunodeficiency disorders only. Okay, these examples and this Mendelian triads identification is very important. Next, chromosomal disorders. In the chromosomal disorders, you all know that trisomy 21, your Down syndrome patients. What are the symptoms? Basically, this is the most common cause for the mental retardation, and patient will be having the heart disease. Specifically, what diseases? Endocardial cushion defects. And what is this one, guys? This is the simian crease. Okay, simian crease also seen in this patient. And patient is having the umbilical herniaris, intestinal stenosis, and predisposed to the leukemia. When I say leukemia, most common leukemia in this patient is the ALL, most common. But if the patient is less than 3 years, AML type 7. This is the most common in the less than 3 years patient. And what is the most common pathway that the transmitted? This is due to patient is having the meiosis defect. Okay, that one. Next, another question, Edwards syndrome due to trisomy 18. This patient is having what kind of features? Horseshoe kidney is seen in this patient, and also overlapping fingers, prominent occiput, or the strawberry occiput is seen in this patient. Micrognothia, mental retardation is common one. Next, Patau syndrome. Okay, Patau syndrome, trisomy 13. Patient will be having the cleft lip, cleft palate, mental retardation, microcephaly, polydactyly. Umbilical hernia is also common here. Patient is having the rocker bottom foot, that is seen in the Patau syndrome. Next, these two classic syndromes, Klinefelter and the Turner syndrome. Klinefelter is due to double XY, and patients those who are suffering from the Turner syndrome is monosomy X. These are the chromosomal abnormalities. What is the features? This patient will be having the minor breast enlargement, pubic female hair, and testicular atrophy. Obviously, this patient is infertile. Gynecomastia is also seen. This patient will be having the Weber neck and streaked ovaries. Obviously, this patient will be suffering from the primary amenorrhea despite of all the genes is presented. Next, this is the Mendelian. This is not Mendelian traits, non-Mendelian traits, the maternal deletion and the paternal disomy. What is mean by that? If the maternal gene is deleted, paternal is going to duplicate. Okay, that is what the paternal disomy. This is seen in the Angelman syndrome. And this patient always smiling. Okay, even though they have the mental retardation, they're always smiling. The gene is involved UB3A. So maternal deletion, Angelman. Okay, maternal for mother, angel, A for Angelman or A for Amma. So like that you can remember this is due to maternal deletion. So paternal deletion, P for Prader-Willi, P for paternal. Prader-Willi disease. This patient will be having the obesity, mental retardation, SNP gene defect. Next here, this is the another condition. You can recall this is your DiGeorge syndrome. And in the DiGeorge syndrome, what is the features? The patient will be having the 22 chromosome deletion, right? 22 chromosome deletion, and symptoms like patient will be having the cardiac malformation, thymus or the parotid glands are decreased, low set ears, cleft lip, and patient will be also having the small jaw, micrognothia. All this will be leading to the immunodeficiency disorder also. Next, moving on to the MI markers. When the MI markers here in the graph itself, you can see the most common one, which is will be elevated is the myoglobin. Okay, this is the most earliest. But what is the first one? So first one will be your ischemia modified albumin, followed by hard fatty acid binding protein, followed by your myoglobin. And most sensitive or the most specific, that is your troponin. Why this is most specific? Here we can see the troponin is elevated. Along with that, it is also presented after 7 days. So that's why it is most specific. Even if the patient is having the any kind of like reinfraction also, it will be elevated. So that's why it is most specific. And LDH flip. What does mean by the LDH flip? So basically our heart will be consisting of the LDH1. So if the MI patient is having the LDH1, this will be leaked into the blood circulation. But blood circulation, the vessels will be containing the LDH2. But LDH2 is replaced by the LDH1 positive. Then we have to consider it is a LDH flip likely to be MI. Okay, next. And also changes. Basically, what are the changes that is seen in the patients, those who are having the mitochondrial inheritance by time and gross appearance? So in the early, less than 0 to 3 hours, normal only. Open the gross picture, you don't see anything. But in the microscopic, the patient will be having the waviness. Okay, waviness and irreversible changes. Okay, irreversible changes are seen in the microscopic picture. And more than 4 hours, to 12 hours patients, there will be a dark mottling on the gross picture. Coagulative necrosis is already seen. Okay, coagulative necrosis is already seen in this patient. And after 24 hours, or less than 72 hours, there will be yellow pigmentation. And this is due to what? Coagulative necrosis, along with that, neutrophils is already came into the site. This is the reason they will be having the yellowish discoloration. And less than 7 days, these patients will be having the high chance there is a rupture due to macrophages are in the site. So neutrophils, coagulative necrosis, and the macrophages likely to be rupture is happened in the 7th day. And after 7 days or the 10 days, over this time, it will be converted into the red color and going to cause the granulation tissue. Okay, these microscopic changes are very important. This topic is the sexual paraphilias. These are the most commonly asked questions, direct questions you can answer. First one is the fetishism. What is this fetishism, guys? Patients, those who are taking the inanimate objects, okay, for the sexual gratification, where they use the inanimate objects, that is the fetishism. And pedophile, who is the pedophile? Which will be using the prepubescent children or the children patients, these for the sexual gratification, that will be pedophile. What is the sadism? Sadism means the partner will be going to induce the pain for others. Okay, induce pain on others. And what is the masochism? Masochism means they are getting pain from the partners. Okay, pain from others. Okay, this is the masochism. Whatever the transvertism. So transvertism is usually they are going to get ready with the opposite gender. Okay, opposite gender clothes. This is the transvertism. And we also have the other one, that is what? Voyeurism. What is the voyeurism, guys? Usually they are rubbing the genitals in the public places. Okay, rubbing genitals or to the others on the public places. So exhibitionism. What is mean by the exhibitionism? Basically, this is due to exposure of the genitals in the private place or the private parts in the public places. Okay. Next one is the voyeuristic behavior. What is mean by the voyeuristic behavior? This is the peeping into public life of their sexual life, anything, their voyeuristic behavior, that is the one of the violations only. And the other types is your nymphomania. So nymphomania is usually increased sexual attention in the female. And coming to the satyriasis, this is seen in the patients those who are with the males. So males will be having the high sexual gratification, that is known as satyriasis. Okay. Next one is the hernia. So coming to the hernia, there are two most common overall in the males, in the females, old age, everyone, that is indirect inguinal hernia. Okay. And femoral is most common in the females. Okay. It does not mean females have the most risk of femoral. When it is femoral, most commonly in the females. But most common overall is still indirect only. And most severe. So most severe is femoral again due to strangulation. So it is divided into the indirect type and direct type. What is mean by the indirect or the direct? So when I say indirect inguinal hernia, this is due to lateral to the inferior gastric vessels. Okay, inferior gastric vessels. And this hernia is medial to inferior gastric vessels. Okay, indirect hernia will be passing through inguinal ring. Okay, the intestine matter is going to passing through the inguinal canal, and this is going to pass through posterior side of the abdominal wall. Okay, posterior side of the abdominal wall. And what is the treatment? Same, hernioplasty and the herniotherapy. But you have to classify which type of the hernia according to the New York scale. So type 1 is for the indirect inguinal hernia. Type 2 indirect inguinal hernia, which is dilated to the internal angle. And type 3 is posterior inguinal hernia. This is your direct hernia, right? So in that subtypes, 3A for the direct hernia, 3B for the indirect hernia, and 3C for the femoral hernia. Type 4 is the recurrent one. Okay, so these classification can be asked in the examination. So next, coming to this question, what is this question? This is last in the FMG examination. It is asked. Here you can see this is the lungs only. Okay, this is the lungs only. But here you can see this is the intestine contents. What is this condition? Congenital diaphragmatic hernia. So these congenital diaphragmatic hernia, the most commonly is due to Boswell's hernia. Okay, Boswell hernia. And this Boswell's hernia is most common and seen in the left side, and posterior lateral side is the best side that we are going to visible. And in this patient, the bag mask ventilation is contraindicated. What we can give then? You can go for the patient's ventilation. Mechanical ventilation is preferred for these patients. What is the defect? Basically, the defect of this patient is the congenital due to pleuroperitoneal membrane defect. The next topic is the head trauma. In the head trauma, the most commonly asked questions from the epidural hematoma and the subdural hematoma. So the bleeding due to epidural hematoma is the mostly the middle meningeal artery, and this is due to 70% vehicular accidents only. What is the symptoms? The patient will be having the specifically the lucid interval will be seen in this patient. And how on the CT scan, on the NCCT, you will be seeing the biconvex lens. So these biconvex lens, this blood accumulation is seen and it does not cross the suture lines. First thing, and next one is the subdural hematoma. And subdural hematoma is due to tearing of the bridging veins. What is the epidural? Due to meningeal artery, and this is due to bridging veins. And it can be acute, or it can be subacute, or it can be chronic also. And on the NCCT, you will be seeing the sickle shape. S for subdural, S for sickle shape. And it will cross the suture lines, right? This is the major difference from the epidural and the subdural hematoma. What about the subarachnoid hemorrhage? In the subarachnoid hemorrhage, this is the picture that you will be seeing. Mostly causes will be hypertension, or the patient will be having the post like polycystic ovary disease, or the patient is having the polycystic kidney disease. That will be the major causes. And the patient will be having the severe attack of the thunderclap headache and vomiting, neck stiffness, meningeal irritation. All this will be seen in this patient. This is the classic picture where you can see the blood accumulation in this patient. And what is the treatment? Mostly all this will be considered as a craniotomy procedures only. So triage for the emergency people, for the black, it is for the dead people. Okay. And red is for dead patients. I mean, they are going to dead in hour. Okay. They are still alive, but they will be going to dead only. And what is the yellow? Yellow is for the urgent referral. You need to intervene immediately. The patient will be saving. All right. Next one is the green. In the green patient, it can be delayed also. Okay. Green patient can be delayed. For example, a fracture, you have to make the splint, you have to make the procedure post also. But green can be delayed. And blue patient is mostly OPD basis only. They can be sent home and expected management next day also. So this is also triage asked questions only. Next one, coming to the abdominal trauma. So when I say abdominal trauma, it is two types, right? Penetrating, or it can be due to blunt trauma. So in the penetrating trauma, the most common will be your liver. And in the blunt trauma, most common will be spleen. And seat belt injury also present. In the seat belt injury, it will involve the mesentery. Okay. And when you say abdominal trauma, let's say the patient is hemodynamically stable or unstable. Let's say if the patient is yes, then go and do the CECT, contrast based CT scan should be done. If you see it is a low grade, then conservative treatment. But if you see it is internal bleeding, patient is having the major injury, then you have to go for the laparotomy immediately. And if the patient is unstable, then do the fast or the E-fast. Then if you see the blood, go for the laparotomy. No blood, then consider the conservative management. Next, here the picture. What is this maneuver, guys? This is the Pringles maneuver. Okay, this is the Pringles maneuver. What they are doing? They're actually clamping the portal triad. This is the portal triad. You have to clamp it for the 15 minutes. At least 10 to 15 minutes, you have to clamp. This is where the location of foramen of Winsley. Okay, to decrease the bleeding into the liver rupture. That is why you have to perform this maneuver. Next one is the pneumothorax. Pneumothorax patient, here you can see this is the affected site and this is normal. Likely to be this patient is having the collapsed lung this side. This is already collapsed. And here this is completely hyperinflated. Hyperinflated lung you can see. What is the one thing that you have to notice in this patient? The patient will be having the increased jugular venous pressure. Increased jugular venous pressure and increased respiratory rate, increased heart rate. But hemodynamically unstable patient will be having the BP low. When you do the auscultation, patient will be having the hyperresonant and no breath sounds on the affected sound on the affected side of the lung. What is the immediate treatment that you have to do? So immediately you have to do the needle thoracentesis. Okay, needle thoracentesis should be done. At what location? Fifth intercostal space, mid-axillary line. Mid-axillary line, it should be done. How about children? In the children, it is done in the second intercostal space, mid-clavicular line. And after doing the needle thoracentesis, you have to place the chest tube. Okay, chest tube should be placed here. Next one, types of ulcers. Okay. In the types of ulcers, you have the sloping one. Okay, this is the sloping one. Commonly seen in the patients, those who are having the healing. And the next one is the punched ulcers. Okay, this is punched out. This is seen in the syphilis patient, bed sores, and undermined ulcers. This is the undermined. TB patients, it is commonly associated. Next one is the rolled out. Okay, this rolled out seen in the basal cell carcinoma. Next one, everted. Along with that, you will be seeing the raised type. Okay, this is everted and raised ulcers seen in the squamous cell carcinoma. These types of ulcers is also asked question. So let's meet in the next video tomorrow. Expected topics of 30 plus in tomorrow video. Until then, stay tuned. Don't forget to subscribe and share with your friends.